Hello, this is Dr. Tony Talebi, and this lecture pertains to the Transfusion Medicine chapter of Hematology and Transfusion Medicine Board Review Made Simple. The ABO system. Healthy persons produce IgM, anti-A, and/or anti-B antibodies called isohemagglutinins, directed against respective antigens. Since antibodies IgM, it can fix complement and produce severe intravascular hemolysis. So a patient who has type A blood will produce anti-B IgM. Patient who has type B blood will produce anti-A IgM. Patient who has type O blood will produce anti-A and anti-B, so they're a universal donor. And person who is type AB will not produce any anti-A or anti-B IgM, so therefore universal acceptor. The Rh system, encoded by two genes, RhD and RhCe. Rh positive individuals express both genes, whereas Rh negative individuals only express CE but not D. Rh protein is involved in the ammonia-hydrogen exchange. Rh antigen is highly immunogenic, and that is why it's so important. Remember, Rh negative mom, Rh positive baby need to administer RhD immunoglobulin RhoGAM at 28 weeks and at delivery. Very important to distinguish partial D antigen from wild type D antigen. It's possible to have Rh partial D, a D antigen which is slightly different than wild type D. In this scenario, the patient is still considered Rh positive but may develop anti-D antibodies once transfused with Rh positive blood. Therefore, these patients should be considered Rh negative and be transfused Rh negative blood and will require RhoGAM during pregnancy. Other RBC protein antigens, KAL antigen, very immunogenic and can cause severe hemolysis. A weakened expression of inherited KAL antigen may be associated with a rare phenotype called McLeod phenotype due to deficiency of a protein called KX. This is the same gene cluster as chronic granulomatous disease. Think of this in a patient with chronic granulomatous disease who has spur cells, acanthocytes on smear. Next, KIT antigen can cause delayed hemolytic transfusion reaction. Next, Duffy blood group may cause acute or delayed transfusion reaction. The MNS group, they reside on top of the glycoprotein A and B antigens and are quite immunogenic. Lewis and P antigen, common target for cold reacting IgM alloantibodies, and the cold IgG, which is the Donald-Lance center of PNH. I antigen, target for IgM-mediated cold autoimmune hemolytic anemia. Platelet transfusions. Alloimmunization, meaning patient producing antibodies against non-self antigens to HLA antigens, is the major cause of immune-mediated refractoriness to platelet transfusions in patients undergoing chronic platelet transfusion therapy. But remember, in addition to anti-HLA antibodies, platelet-specific antigen, the HPA antibodies, may also cause platelet transfusion refractoriness. So remember, HPA-1A/1B can cause neonatal alloimmune thrombocytopenia, NATE, or post-transfusion purpura, PTP, or may cause platelet transfusion refractoriness. Post-transfusion purpura case report: 60-year-old female receives a blood transfusion for GI bleeding. 2 weeks later presents with severe thrombocytopenia, but not anemia. So what happened? Always check for HPA-1A/1B antibodies. For some reason, antibodies produced against the transfused RBCs cross-react with autoplatelets and cause platelet destruction. Patient presents with thrombocytopenia 2 weeks later. Treatment: IVIG and transfuse HPA-1A negative platelets in the future. There are two types of platelet transfusions. One, pooled platelets, derived from 5 or 6 volunteers, so donor platelet count varies considerably, or single donor apheresis platelets, derived from one individual, so all platelets are the same. Some prefer a single donor over full platelets as it is less alloimmunogenic, but the data does not support this. A 6-pack unit of full platelets contains about the same number of platelets as a 1 dose of single donor apheresis platelets, at least 3 times 10 to the 11 platelets, so should increase platelets by at least 10,000. The corrected platelet count increment, the CCI. Platelet survival after transfusion is related to the dose of platelets fused as well as the patient's body surface area. The corrected platelet count increment, the CCI, equals platelet increment in 1 hour post-transfusion times the body surface area divided by the number of platelets infused times 10 to the 11th. The expected platelet increase is the platelet infused times the CCI divided by the BSA. The theoretical value of CCI is 20,000, but clinically the value is more like 10,000. If the CCI is less than 5,000, the patient is said to be refractory to platelet transfusions. Transfuse platelets if platelet count is less than 10,000, or if patient bleeding and the platelet count is less than 50,000, or in the case of central nervous system bleeding, less than 100,000. Platelets usually survive 7 days in healthy individuals, but only 3 days in patients undergoing chemotherapy. Formula for platelet transfusion is 1 unit per 10 kilograms of body weight. For example, an 80-kilogram patient requires quote-unquote 8-packed random donor platelet transfusion to increase platelet count by at least 10,000. Platelet transfusion refractoriness, case report. 57-year-old male with MDS has been followed more than 7 years, receives frequent blood transfusions and platelet transfusions. In this interval, he's developed platelet transfusion refractoriness, meaning platelet count rise of less than 10,000, with each random donor platelet transfusion. So he starts out with random platelet transfusions, with only completely HLA matched platelet concentrates being effective initially. But gradually, however, the effectiveness of the 2 completely HLA matched donors' platelet concentrates are also decreased. The patient's HPA, the human platelet antigen typing, is done. So remember, if the patient becomes refractory to HLA identical platelets, the next testing is you have to test for the HPA, the human platelet antigens. So here, the typing is done. Discover that the patient's HPA5 phenotype is A-, B+, whereas that of the 2 donors' HPA phenotype is A+, B+. Therefore, anti-HPA5A antibodies are detected in the patient's serum, with its titer increasing gradually during repeated transfusions from these 2 A-, B+ donors' platelet concentrates. Patient is subsequently transfused HPA5A negative platelets, and adequate rise in platelet count occurs. So, very simple. First, platelet transfusion refractoriness occurs, transfuse HLA matched. If that doesn't work, look for the HPA antigen and match HPAs. Refractoriness, platelet transfusion refractoriness is defined as 2 consecutive post-infusion platelet count rise increments less than 10,000. It's usually due to alloantibodies to HLA and sometimes alloantibodies to the HPAs. Can detect anti-HLA antibodies via plasma reactive antibody, the PRA. If the PRA shows anti-HLA antibodies, then select platelets based on HLA matching. Most platelets will express HLA-A and HLA-B antigens, so most blood banks will at least attempt to optimize those 2 HLAs. But even HLA matching does not guarantee adequate rise after platelet transfusion, so some advocate platelet cross-matching, similar to blood cross-matching. The best way to reduce HLA alloantibody formation is to minimize passenger lymphocytes that are transfused along with the platelets, which are responsible for the HLA alloantibody formation. So the best way is to first to glucoreduce, then irradiate. Best to order irradiated and filtered either 6-pack pooled or 1 unit of freeze platelets. Pretransfusion testing. 1. type for ABO and RH group. Next, screen the potential donor and recipient to discover non-ABO, non-RH antibodies, either autoantibodies or alloantibodies. If the patient's serum does not react with either screening cell, then the patient is said to have a negative screen, and ABO-compatible units can then be cross-matched between the potential donor and the recipient. If the screening test is positive, then the patient's serum is run against a larger set of reagents, typically 11 to 16, referred to as an RBC panel, to identify the antibodies. Patients with autoimmune hemolytic anemia are difficult to cross-match due to autoantibodies. In patients with autoimmune hemolytic anemia, presence of alloantibodies may be masked by autoantibodies. You need to perform a technique called absorption technique to differentiate the two. Transfusion-induced graft-versus-host. Case report. 78-year-old female transfused leukocyte reduced but not irradiated factor RBC and platelets. 2 weeks later develops rash, jaundice, elevated LFTs, and diarrhea. CBC revealing pancytopenia. So what happened? This is caused by immunocompetent donor lymphocytes that mount an anti-host response after 2 weeks. The big difference here is that the graft-versus-host from the transfused leukocytes cause severe pancytopenia, which can actually cause high mortality. Donation from close blood relatives may lead to haploidentical donor lymphocytes causing graft-versus-host. Prevention depends upon irradiation of all cellular components to render the lymphocytes impotent. Apheresis. In apheresis, one plasma volume of patient plasma is removed and replaced with 5% albumin, or FFP in the case of TTP, which is combined with the patient's cellular blood elements in the extracorporeal circuit and returned to the patient. The Category 1 recommendations for apheresis you should know. 1. Chronic inflammatory demyelinating polyradicular neuropathy, CIDP. Cryoglobulinemia. Cutaneous T-cell lymphoma, mycosis fungoides. TTP. Goodpasture syndrome. Familial hypercholesterolemia, the homozygous ones. Hyperleukocytosis leukostasis. Guillain-Barré. Myasthenia gravis. Sickle cell disease. Life or organ threatening. Hyperviscosity monoclonal gammopathy. Now for exchange transfusions, indications in sickle cell patients to perform an exchange transfusion to achieve a hemoglobin S less than 30%. 1. Acute stroke in children or adults, either ischemic or hemorrhagic. Next, acute chest syndrome. Next, when surgeon intends to create a dry field using a vaso-occlusive tourniquet. Next, complicated surgery requiring more than 30 minutes of general anesthesia time. Next, children at high risk for stroke or stroke in the past. Acute ocular occlusions. Acute splenic or liver sequestration crisis, or priapism. Massive transfusion, case report. 19-year-old male presenting with internal organ injury following a motor vehicle accident, requiring 14 units of blood transfusions in a row. Subsequently develops hypothermia, prolonged QT, hypocalcemia, thrombocytopenia, elevated PT, PTT, and low fibrinogen. So what happened? This is defined as the replacement of one blood volume within 24 hours, typically 4 to 6 hours after severe trauma or major surgery. Causes a decrease in coagulation factor levels less than 50%, therefore causing the elevation of PT, PTT, and low fibrinogen, thrombocytopenia, dilutional, hypocalcemia, and prolonged QT interval, and hypothermia. So monitor PT, PTT, platelet counts, fibrinogen, and electrolytes. Treatment: replace coagulation factors and electrolytes as needed, warming blanket, and tele and cardiology consultation if patient develops prolonged QT. Cardiopulmonary bypass surgery-related thrombocytopenia. Case report: 65-year-old male with normal CBC undergoing CABG. 2 hours before surgery has a platelet count of 55,000. Normal PT, PTT, so not in DIC, no fever, no infection, no bleeding, and normal creatinine. Platelet abnormalities account for most cases of correctable non-surgical bleeding following procedures. Platelet dysfunction and aggregation may result from the platelet contact with a foreign surface of extracorporeal circuits, including pumps and aortic assist devices. Use of 2B3 inhibitors prior to surgery worsens the problem. Remember, must rule out DIC, infection, TTP, and HIT. Treatment, platelet transfusion if needed, and await recovery. Acute hemolytic transfusion reaction. Case report. 15 minutes after receiving packed RBC transfusion, patient develops fever, back pain, rigors, hypotension, red urine from hemoglobinuria from intravascular destruction of RBCs, LDH elevated, and, very important, direct Coombs positive for both IgG and complement. So, difference between acute hemolytic and febrile non-hemolytic would be that you would see red urine and positive Coombs test. This is typically due to clerical error and mislabeling patients and donors ABO type and cross-match. The ABO isohemagglutinin are complement fixing and lead to severe intravascular destruction of the transfused RBCs and massive cytokine storm causing fever and chills. The serologic hallmark in the acute hemolytic reaction is a DAT that demonstrates both IgG and complement on the surface of the recipient's RBCs. Treatment, supportive care, obviously, stop the transfusion, supportive care, IV fluids to flush the kidneys, and vasopressors if hypotensive. 2 organisms you have to know for risk of bacterial infections of blood products: Erinacea, Enterophilitica, and Borrelia burgdorferi. Very rare, but most of both organisms for the hematology boards. Delayed transfusion reaction. Case report. 64-year-old male, O-positive male, receives 12 units of group O-positive RBCs during surgery. Pre-op has no antibodies detected on the RBC screening, but had surgery 20 years ago, and this is the key, in which he received a blood transfusion. He becomes jaundiced 2 days after surgery with elevated LDH, indirect bilirubin, as well as low haptoglobin. So what happened? The patient has formed allogeneic antibodies after re-exposure to the antigen from the RBC transfusion 20 years ago, which he saw again during the surgery. And these were subdetectable on his original type and screen. After a new blood transfusion, allogeneic antibody reemerged, so you need to obtain a new type and screen. This is usually seen with the KID antigen, IgG-mediated and thus extravascular. Treatment, once L antibody is discovered, transfuse appropriately cross-matched blood. Febrile non-hemolytic transfusion reaction, FNHTR, case report. 43-year-old male who has never been transfused before, receiving 2 units of, very important, non-leukoreduced packed red blood cells after surgery. That's the key word, non-leukoreduced. 30 minutes into the transfusion, develops rigors, fever, tachycardia, tachypnea, without O2 desaturation. No back pain, fully with yellow urine, so no hemoglobinuria. DAT is negative. So this is what differentiates between febrile hemolytic and non-hemolytic. Febrile non-hemolytic transfusion reaction is due to leukoagglutination of recipient origin directed against transfused donor WBCs. Cytokines derived from donor leukocytes that become activated during blood storage may also produce it. Only way to avoid it is leukoreduce the packed RBCs. Negative DAT makes acute transfusion reaction unlikely. Treatment, transfuse leukoreduced RBCs and stop transfusion to rule out acute hemolytic reaction and supportive care. Viral risk of blood transfusion. Remember, hepatitis B has the highest risk of transmission, not hepatitis C and not HIV. Passenger lymphocytes may also carry CMV, so irradiate and leukoreduce the RBC transfusions. And CMV will become more apparent when we discuss the transplant chapter. Transfusion support in aplastic anemia. Very important. Direct blood transfusion from family members is contraindicated because it may sensitize the stem cell transplantation antigens. If needed, transfuse non-sibling derived irradiated to reduce graft-versus-host and leukocyte depleted to decrease likelihood of allosensitization as well as CMV, blood products. Allergic reaction to blood transfusion. Case report. 22-year-old male with IgA deficiency receiving a blood transfusion developed severe hypotension and shock. No evidence of hemolysis. He's normal LDH negative Coombs or back pain. Many urticarial reactions are donor-specific and thus do not recur with subsequent transfusions. If a recipient experiences multiple urticarial reactions, then consider pre-medication with antihistamines and or wash products. Resuspended in albumin and saline. IgA-deficient patients may produce anti-IgA antibodies that may cause anaphylactic reactions. Treatment: extensively wash the future transfused RBCs or pick donors who are also IgA deficient. Post-renal transplant erythrocytosis. 15-year-old case report. 15-year-old boy developed severe erythrocytosis 7 months after successful kidney transplant with a well-functioning graft. Hematocrit rising above 60% with normal oxygen saturation. This actually may occur in 10% of renal transplant patients due to the renin-angiotensin system. Treatment: ACE inhibitor. Passenger lymphocyte syndrome. 40-year-old man presenting with acute hemolytic anemia received a small intestine transplant, this is important, 2 weeks earlier, and was transfused a single unit of packed RBCs on day 1, +1 of transplant. Now presenting with icterus, hemoglobin 6, LDH elevated, low haptoglobin, peripheral blood smell revealing spherocytes, and polychromasia. So there's clearly hemolysis going on. Patient's blood type is A positive, and the donor's is O positive, so the donor has anti-IgA antibodies. Coombs test is positive. Hemolysis is brought on by passenger lymphocytes in the small intestine. The immunocompetent donor B lymphocytes from the donor transplanted organ, the small intestine in this case, are producing anti-A antibodies, typically self-limiting to only a few weeks. Treatment: treat donor with anti-lymphocyte antibodies or steroids to reduce transplantation of T lymphocytes, which activated the antibody-producing B cells. Red blood cell transfusion. Case report. 67-year-old man with CLL has a positive direct and indirect Coombs test. What type of blood will you transfuse him? Answer: ABO and RH least incompatible blood. Coombs test indicates an autoantibody to common red cell antigen, usually RH, and often is impossible to make a compatible cross-match. In the presence of autoantibody, should transfuse the least incompatible blood you can identify. Blood bags should be asked to exclude red cell alloantibodies that may be masked by an autoantibody. There's no added benefit for washing RBCs, because they deplete plasma proteins only. Gamma radiation of RBC kills live leukocytes, so less graft-versus-host. If the patient has an autoantibody, there's no need to transfuse HLA-matched blood, since the antibodies are against common red cell antigens and not HLA antigens. If transfused back RBC in the setting of autoimmune hemolytic anemia, unlikely will develop acute hemolytic reaction, but rather the RBCs will have a shorter lifespan. Platelet transfusion. Case report. 35-year-old male, A positive blood group, received an allo stem cell transplant from his HLA-matched brother, who was group O positive, so has anti-A antibodies. On day +7, he's transfused platelets, and 1 hour post-transfusion count reveals the platelet count to be increased from 8,000 to 19,000. So bottom line is that's an adequate rise. However, the next day platelet count is decreased to 11,000. There's no splenomegaly. So what is the problem here? Initially there was a good rise, but then the next day the platelets are back down low. Failing to achieve adequate response to platelet transfusion is referred to as platelet transfusion refractoriness, if observed repeatedly. So check platelet count 1 hour after transfusion, followed by periodic count to see if it's sustained. The actual increment observed depends upon the size of the patient, as well as the number of platelets transfused, the CCI, which we discussed earlier. Poor increments caused by immediate destruction of transfused platelets So 1 hour post-platelet transfusion checking indicating less than 10,000 rise in platelet count usually indicate immune-mediated destruction of transfused platelets and are suggestive of either HLA or HBI immunization. Decreased post-transfusion survival following a good initial response indicates a non-immune destructive mechanism. Remember, 1 dose of apheresis platelets equals 6-pack full platelet concentrates. So in this case, after stem cell transplantation, you need higher doses of platelet transfusions due to endothelial injury, so pseudo-refractoriness. So simply transfuse more platelets. So remember, if the 1 hour post-transfusion platelet count is okay and the platelets are decreased the next day, this is due to other etiologies than acute immunologic destruction. Transfusion-related acute lung injury, TRALI. 50-year-old male with MDS receives a blood transfusion, which is leukoreduced and irradiated. Subsequently, 3 hours later, develops respiratory distress without wheezing. Pulse ox revealing oxygen saturation has decreased 87% of room air, bilateral growls audible, slightly hypotensive, low-grade fever, no rash, echo revealing normal EF, so this is non-cardiogenic pulmonary edema, and checks X-ray with bilateral pulmonary infiltrates. TRALI is due to leukoagglutinins, donor alloantibodies reactive against autoleukocyte antigens that cause activation of granulocytes in the pulmonary capillary bed. Important to note that TRALI is due to donor alloantibody, either anti-neutrophil or anti-HLA antibodies, and in febrile and non-hemolytic transfusion reaction, the leukoagglutinin is due to the antibody of recipient origin and is directed against transfused donor leukocytes. TRALI is usually seen after the platelet or FFP transfusion, but higher titer of leukoagglutinin have been implicated in RBC transfusions. If reaction is severe, ARDS may develop. This is seen in high frequency from multiparous female donors who have higher HLA antibodies due to pregnancies and exposure to paternal antigens. Must identify the donor, as he or she may never donate blood products again. It's usually self-limiting and patients improve quickly, but associated with some mortality as well. Treatment, supportive care. This concludes the transfusion medicine chapter. Thank you.